Very good afternoon, all of you. Thank you very much for joining here. And mine is slightly different from the previous two speakers. I hope that you can reflect as I go along, because it is right down into all the hearts of the human being and other animals here. And I always tell in my department, OBGYN department at any age, if there is no sex, no OBGYN at all. And you understand? Sex is so important for making the babies and etc. So I used to tell them, if there is no sex, the Department of Obstetrics and Gynecology doesn't have to exist. So I'm given this topic by the center where I am now, Novena Center. Maintaining sexual health as you age. That means from the beginning to the newlyweds to the elders, and it's part and parcel of your heart. So I will touch upon, like in these young couples who are having some problems, to the older ones up to menopause and andropause, and it will be a bit of a wide thing. So it's going to be just a review for all of you. Sexual health is very much connected to general health. If the general health is good, you may not have the sexual problem at all, and I will tell more about that later. We approach sexual problems and the concern in a very holistic way. Urologists are very expert in these things, and then they give these drugs and then directly, like Viagra, but I go beyond that level. It is the story about Viagra is not the only thing for the problems of sexual things. It's just varied, and it's a lot of things are involved behind the scene. And all those things have to be looked at, something like psychological factors, hormonal factors, medical, and couple relationship. The couple relationship is extremely important. In such cases as this kind of PD inhibitors, so-called Viagra and other compounds that we are having now, may not even work all over the world. About 40 to 50% of the people may not be successful with such drugs. That's partly because there's a lot of other issues has to be tackled holistically. We provide education about sexual health and strategies to maintain healthy sexual functioning throughout the age. And what are the things in the relationship therapy that we can look at? Evaluation of the male and female sexual difficulties. The difficulties are varied. It's a lot of different kind of difficulties. Counseling and sex therapy for individuals and couples. Intervention for unconsummated marriages. You will be very surprised for me to give you the information about unconsummated marriages. In annuage, in my study, at the clinical prevalence, it's about 10%. And that it's not just 1 year of unconsummation. My highest number was 25 years of unconsummation. So that's sort of a varied things that we have. Sexual concerns addressing fertility. Fertility issues, the sexuality, how it plays a role, and then our prevalence and our frequency of sexuality in Singapore is not that great. So how we have to advise these young couples about that. Sexual performance anxiety is a psychogenic component, and that is invariably mostly for the men, about 80%. Ladies also suffer from sexual performance anxiety. And in my basic research, long ago, 3 decades ago, working onto the human penis and the smooth muscles, how it works, how it can create this sexual performance anxiety, all these things can be explained to the patients. Sexual rehabilitation to regain intimacy, and that's also very important. When the couple come to the clinic, they come with a lot of negative bags on them. Those things has to be relieved, and regaining intimacy is extremely important in this modern time. And also, I'm also thinking into introducing this premarital counseling, because having seen these patients up post-marriage and up to the older age, and if somebody is coming without any major good knowledge about sexuality and getting married, that's where the problem all comes. Not just simply the sexual problem, as I mentioned, all the other related things all. So it would be nice if people can come forward and for this premarital counseling. Definitely 100% the benefit will be there for them. And then how this counseling all can enhance the patient's acceptance. Self-acceptance comes in when an expert is telling them. Otherwise, they are shrunk inside. They don't go and see the doctors. They don't seek help anywhere. Friends and anybody, they don't mention. The couples suffer themselves, most of them. And empowering them is also very important. And then helping the patients to cope with partner. If one person is coming, please you bring your partner as well. And then partner counseling has many benefits. So I will just go with some of these important points here that is mentioned in relation to the sexual dysfunction affecting fertility. ED is erectile dysfunction. Formerly it was called impotence. That's not a nice word. Even now, in the last 10, 15 years, it's called ED, and people are thinking about changing this. Instead of calling erectile dysfunction, why should we say dysfunction? It's just a problem, simple problem, erectile problem. Vaginismus is a condition the lady is suffering from, some of the ladies, and it's very automatically they will shrink their vagina and then the pelvic muscles, and that can also prevent and create ED, and that definitely is a concern for fertility because they can hide these things from the public and from the parents and etc. for some time until the big pressure comes for them to have the baby. Then it gets revealed when they come to the ONG department. Severe premature ejaculation. PE is premature ejaculation. Very severe premature ejaculation means you can't even consummate. And that also contributes to the fertility problem. Any ejaculation is completely unable to ejaculate. They've got a number of the clinical prevalence is about 5% in Singapore. The 5% of them, they completely cannot. And of course, there are some traumatic things like spinal cord injury, etc. But then this is a psychological factor. If there is time, I can explain why this happens and etc. later. Low frequency of sexual activities. That's also, it's very common in Singapore. Singapore probably is one of the best record holder in these things. I have a slide to show you later on. Low desire is one condition that with low desire for sexual activities, the man or the woman are not interested in engaging. And that will create a lot of infrequency. Interpersonal issues is the most important part. So here, just to show you an example of my very old study, 1,036 patients, I looked at the erectile dysfunction, premature ejaculation, and unconsummated marriages.
This is a TV screen.
Oh, so you can't.
Yeah.
Okay. So out of that, the male problems creating this unconsummation is 70%. Female issues is about 30%. You can see that. And ED, PE, and unconsummated marriages. What causes the unconsummated marriages? Vaginismus for the female, and then severe premature ejaculation in erectile dysfunction for the male. Young people, and they have these things. I will explain later how this is happening. So these are some of the major problems for men. There are other problems also, but then the major problems are these disorders of erections. The disorder of erections can be quite a different stage level. It can be a very 100% erection, it's called penetrable erection. But if it is like 70%, 80% also, the penis can buckle. And then once it buckles, and on the first night of the marriage, getting together after wedding, and if the man is failing with that buckled, and then he's very devastated, he's go down to the hill. And after that, you won't get up at all. Nobody will know how he is suffering internally. And that sort of thing can happen. Disorder of erections can be even maintenance problem. It is possible to go inside the wife, and then while he is inside, and then things can go down. It's not getting up. So things are not going nicely over there. A lot of pressure, a lot of stress. Maybe talking about the share markets and things falls down. His penis also can fall down. So many factors are there. I explain here premature ejaculation wise, premature ejaculation, delayed ejaculations, an ejaculation I just explained to you. Retrograde ejaculation is instead of shooting the sperm outside, the sperm goes inside the body into the bladder. Not to the original place seminavasicles, but it goes into the bladder. So that's a retrograde ejaculation. This also will be alarming for them. They can't see the sperm, but he can get an orgasm. And so when they come to the fertility clinic and we can do something to overcome this and then ask some questions and we know what it is, then after urinations, you see, you collect the sperms from the urine for the fertilities. Retrograde, going inside. Why it goes inside? The bladder's tip, the trigone, is a bit weak. So instead of shooting antegrade, it goes retrograde into the body. It's not very many. Any ejaculation, 5%, this is much less. But delayed ejaculation is not a big problem. We don't see this, elder man maybe, and then he has to, or the sensitivity of the penis, the glans penis is not sufficient enough to trigger the feedback for the ejaculations. So he goes on like 20 minutes, 30 minutes, and both the partners, husband and wife, will be suffering. And that, if they come for the professional support, it can be done. It can be overcome. The third one is desire, as I mentioned to you, and then the arousal. The stages in this sexual physiology is, first of all, is a desire must be there. There are two kinds of desire. Libido is systemic. It's in the body-related libido, hormonal, and etc. But then the person's interest to have sex can diminish. That's desire. But arousal is on the time of the engagement with the partners. That arousal must come in, that the engorgement, there's a blood supply, warming up, and etc. during foreplay. That's called arousal. At the peak of the arousal comes the orgasm after engagement inside. So now I will concentrate a little bit for another 5-10 minutes on the erectile dysfunction, because this is the main problem of the man compared to the rest. It's two kinds. One is organic. It's a physical problem, as spoken by others here. Then there's a lot of components that can contribute to this, like vascular problems, blood vessel problems, neurogenic, nerve problems, hormonals, and anatomical, structural, the birth defect and etc. All these things can be considered as organic. Drug-induced also is there, but then I shouldn't put it here. But you can also see psychogenic factors and the mix organic and psychogenic. Here we, in the 90s all, we thought that mostly it is organic at 80%. Previously in the 60s all, during Master and Johnson's time, it is all in the head, 90% is psychogenic. So it varies. And to me it is about 50-50. And also many men will be suffering from both. In the 40s and 50s there will be some organic factor as well as psychogenic factors. Psychogenic factors is nothing wrong in the body, no blood pressure there in this, but it's the mind is dictating. Now the organic factors, what are the compounds causing this? Hypercholesterolemia, high cholesterol, high triglyceride, diabetes, peripheral vascular disease, the constriction of the blood vessels, and then hypertension, BP, hormones, aging itself also. All these things can contribute towards this. You see, another interesting thing that came out in the world for us in our field in the last 15 years, we found that ED may signal cardiovascular ailment because the corpus cavernosa muscle of the penis inside here, this one and this one, that has got very small blood vessels. This is a coronary artery which causes the heart attack. This is much, much bigger than this one. But if there is some problem here, it affects this first. So if some of you or me, if we are going to think that we are having some problem with erections, in the 40s, say in the 40s, oh, I'm having some problem, that's a very good indication. Eventually, you may also get coronary blocking with cholesterol. So that's why we call it ED may signal cardiovascular ailment. Then there is something called metabolic syndrome. We have got, which metabolic syndrome is the same thing. So diabetes, hypertension, hypercholesterol, all these things considered as diabetes together with obesity. And this obesity is very, very bad for men particularly because a lot of estrogen-related fat is here. And that is what happens, his testosterone also will go down because all his testosterone here will be aromatized into estrogen. And the aging of the world, lifestyle factors, obesity is the number one nowadays. And if I see a big guy walking like this into the clinic, invariably he has got some problem, sexual problem, as well as the sperm problem, and his testosterone level will be low. Most of them, very obese people. Dietary changes is important, and that's also is causing nowadays smoking, alcohol, lack of exercise. All these are lifestyle factors. Now, that's on the physical component. Now let's see the psychogenic component, how this comes into picture. Fear of performance. For ladies all, men are very brittle. They are not the strongest people in the world. In front of the lady, they even shaking their legs all. That is why the penis also goes inside instead of coming out. Fear of performance is there in many men. It's a trait, but at the same time, it's an adrenaline in the body. You see, when you have you're walking along the line and then the dark, you're the only one. And you are thinking that somebody is coming with a dagger. What will you do? You will run. Huh? You will run out of fear. Your heart is beating faster. And that's adrenaline. That same adrenaline, if I put that into the penis, and in my laboratory, put that tissue, and then put that, the tissue will shrink. Completely it will shrink. So in medicine, we say the adrenergic component is completely shrinking. The cholinergic and the parasympathetic component, the opposing component can relax. So when the man is having fear, his penis can go inside. That is why it's called in the 60s, if you go back to the medical journal, it's Koro syndrome, K-O-R-O, Koro syndrome. The Koro syndrome means the people were all fearing and the penis becomes shrinking and then sucking away. That worse it can be in the mindset. But if a man on the first night, if he's failing, and that's the end, he will keep on failing after that. Fear for pregnancy. During the courtship period, fear of pregnancy, fear of venereal disease, and etc. also can create a temporary ED. And the temporary ED can become permanent. Severe premature ejaculation. When he is undressing, he is trying to kissing the wife here and there, and then he is already ejaculating. This is called very severe premature ejaculation. And also, sometimes 2 or 3 strokes and ejaculating, and he gets devastated. Scheduled sex is a particular, very good example for all of us to remember. Scheduled sex, I call it tonight's the night syndrome. And that happens when the wife and husband, they are married and 3-4 years, no children. Then they go to the doctors and they say, last time all it's ovulation, temperature, monitoring temperature, and the day in the month, this is the ovulation day. Okay. That day she is quietly telling that husband, tonight's the night. That's why I call it when he is going to work. When he is perfectly all right the 3 to 4 years. They were having good sex. But that day she is told this, and he couldn't work there. In the computer, her face is coming all the time. He will come home and he will totally fail. This is a typical scenario with all these things. Tonight's the night syndrome. Initial failure. Okay, that day he fails. Previously is okay. He is going to suffer from secondary impotence. Initial failure snowballs into failure after failure. After that is no more pleasure, no more friendship with the wife. It's all the time he's worried whether it will get up or not. The more you worry, the worse it becomes. Yeah? This is what happens.
Give him some triple X rated movie.
Yeah, so there are a lot of things that the man will become impotent because of the female problems. The sexual difficulty from female and their trait, their disposition, all can do this same story. Pressure to perform, that is making baby, that we pain disorder. If she is having some pain, she is suffering when he is approaching. He is a loving wife. Would he going to suffer? Make her suffer? No, he will go down. Vaginismus. And then they don't know what is vaginismus. The first time she is not allowing the finger, he is not allowing to touch anything. But when he comes closer, she buckles the thighs, and then she couldn't do. And then what happens to him? A normal person will become an ED. These are all psychogenic factors. Dyspareunia is a painful intercourse. And if that happens, have to look at the things. The gynae may look at this, what is inside there, whether it is endometriosis or some lesions, whatever it is, or whether purely a psychological things. So when there is a lot of pressure to the man, some men think that the wife is hypersexual, and they have more worry about them. Dominance and extroversion also, an introvert man will not accept that, and he suffer inside. Some kind of aversion is created, and that will also create problems, sexual problems. So what are the treatment? Now we discussed the physical factors and the psychogenic factors, and there are some way of getting it. Modifying reversible causes is very important. Medication change, because if you are taking some beta blockers, for instance, and it's not going to be very good, there are some medications may not be conducive for good erections. That has to be looked at. Sex therapy, counseling, lifestyle modifications, looking at the hormone level, the testosterone, whether it's in the right place, and etc. has to be. So that's how most of the man can be cleared here itself. If it is psychogenic, then we have to do a lot of homework, sex therapy, homework. Then the first line is oral agents like Viagra, psychosexual therapy, vacuum devices. Second line is intracavernosal and intraurethral. I will show a picture if I have it here now. Then the final stage is surgical. So all these are, most of them can be overcoming at that level up to the cavernosal injection. But surgical prosthesis is very expensive. It's not very common nowadays. So that is intraurethral. It's called Muse, putting some prostaglandins inside the glands, through the glands into the urethra. Or for the maintenance problem, the next one, once the erection comes up, put a band at the base to prevent the blood going back into the body, and so that can hold for a while. But after ejaculation, you shouldn't sleep with that. You must remove that. And this is another vacuum device to create the erection, and similarly put a band from here and slip it down. And the other one is the intracavernous injections. I was one of the earliest to identify the prostaglandin E1 in the world, for which I had some international award and etc. And that has to be given inside the cavernosum into one side of it, very small amount, and that will create. That can overcome the psychogenic factor because it doesn't have to work like Viagra. Viagra requires the brain to use some desires. Otherwise, Viagra like drugs won't work very well, as you all should know. Then the other one is the 3-piece inflatable prosthesis. That can be fixed there, and then there is a pump to press, and that's a reservoir, and you will get this erection coming up and going down. It's the elderly people usually, they will put it up. So that much for the treatment. But beyond these things, the important things, the interpersonal issues have to be tackled. These are the 3 oral medications that we have in Singapore, and it's the choice of the patients to choose. Any of these, they can try all the 3, and the best which suits for each one will be taken. It's very important, any of you, if you are taking, if you take sildenafil and then just wait for 1 hour, nothing will work. and then you may get about 50-60% erection. But in order to capitalize that, in order to have this, there should be a lot of arousal and desire in the brain, a lot of foreplay, and only then you will maximize. It's a bit complicated for me to explain here the mechanisms. I didn't have the slide also. Now I go to the premature ejaculations. The premature ejaculations very much different from the erectile problem. Erectile problem, as you can see, the young man gets about 10% or less, and then it goes up higher and higher, and up to the 75 to 80, you're getting about 50% of them are having erectile dysfunction. But if you look at the PE, premature ejaculation in Asian prevalence, about 5,000 people, I was one of the 3 to do this. It's about 30% in men. And that is there continuously going on like this. So people are born with, maybe genetic factors should be looked at. People are born with premature ejaculation. We call it primary premature ejaculation. There is also secondary, because a normal person also, if there is some pain here or some other issues, the wife is screaming and he can ejaculate earlier. That can be overcome easily. But primary one is very difficult. Nowadays, we have some medications, some behavioral therapy, topical creams, and also tablets. It's 5-HT, serotonin uptake inhibitors. So that's very common. Yes?
Can I ask a question?
Can.
You focus on the negative. What about the positive? The positive is that even at old age, a lot of males still have tendency to have sex.
Oh, yeah. Yes.
It's not as bad as public think.
That's why you can see it's 50%.
Yeah, it's still pretty good.
There are samples, there are a lot of examples around the world. In those days when there were not these drugs, all Viagra, all, and Charlie Chaplin, Picasso, they are celebrities. I mean, among us also there are a lot of people. They were having children when they were 80, and then there is somebody in Hong Kong, what's his name? Shin Kai Sheng or some.
Murdoch.
Huh?
Murdoch.
No, the Hong Kong. Huh? Yeah, 4th wife or something. Yeah, he was having her when he was about 80. So all these pictures I used to put and show. No, we don't forget, because positive is very good. We are talking about this, how to overcome these things. Okay, so another major component I mentioned, lack of sexual interest is playing a big role. Particularly in Singapore, you can see, nowadays we don't see this Durex survey. Used to be every year, and it comes in straight times. And you can see in all other things now we are becoming one. Every day in Singapore paper, we are number 1 in the Keppel, and then we are number 1 in NUS and all these things. But we are also number 1 the other way around.
No. What about Japan? Japan should be right at the bottom.
Is Japan here?
No, it's not there.
Oh, I have another one, big one, sideways. It's a full world I have. This is a smaller one. Anyway, we are not far away from the things. It's very close, 112, 116, 110. But we are down there. It's Hong Kong.
1 in 3 days. 110. How often do you have sex? That means 100.
No, this is per year.
Days out of 365 days.
This is per year.
Huh?
Per year.
Yeah, that's what I'm saying. 100 days out of 360. You know,
Right.
still pretty good. Once every 4 days.
Yeah, that's what I say.
Not bad.
But compared to the rest, well, it's okay.
Maybe old people once in 20 days.
Okay, I will have another slide to show you. That is Singapore slide.
So negative.
Okay, this is the slide, and this one about 10-15 years ago, and I did. Look at this. I divided these patients into 3 groups. A group is 3.2 nanogram of the testosterone level and below. That is about the lowest normal. The middle, the yellow one, is the mid-level testosterone level. The last one here is the upper normal, the better ones, 6.3. And here, different groups. It's not the same person I monitor for these years, but 20s, 30s, 40s, 50s, 70s. And I asked them, if you are treated, they all were having some problem, they come to the clinic. If you are treated, how often would you like to have sex? To indicate their desire level, they tell you this. So here, the young man, if his level is, testosterone level is low, is 2.5 times per month, his frequency, 2.5 times. And that man with a good, better testosterone level is about 7 times per month. But then another factor is, as you go into the group, all of them, whether it's a low level or higher level, they come low, the testosterone level.
See, this is way below our average of 10 a month. 100 times a year, that's 10 a month. Here is all below 10. How can it be?
So
The
this is,
averages don't
but
link
this is
to
not the
direction.
normal people in the town. It's not the community prevalence. It's a clinical setting. It's clinical setting. But what it is telling me is testosterone play an important role in the dictation of the frequency.
Okay.
Yeah? So now we will talk about andropause. We know very well all these menopausal issues. Yeah? But there is also andropause. The only thing is menopause setting in around that 49 to 51, that age, the estrogen goes to the floor very fast. Whereas in men, it's a very slow process, and we also call it late onset hypogonadism. But primary hypogonadism is a young boys, and it's very difficult to overcome that if it is not replaced. This is late onset age-related hypogonadism. But it causes all these things as they become older. It is not only the ladies who are suffering from this. Bone loss, muscle weakness, increased abdominal obesity, and reduced libido is one of the things. Erectile dysfunction also is another one. All these, and reduced hematopoiesis, depressed mood, all these things is happening, even sweating, etc. So when the testosterone level is low, this is happening to them. And even this, when the testosterone level is low, if they are taking any sildenafil, Viagra-like drugs, they may not be able to get a good erections. That's why if these sildenafil-like drugs are not working for you, your doctor will look at the testosterone level. If it is low, he will do a testosterone replacement. Bring up the testosterone level, and then those things, sildenafil-like drugs, will work very well. Because the details are there, a lot of mechanism, a lot of studies has been done on all these things. And this is where I mentioned the brain is the person which will have to have a lot of desire, bring down the nitric oxide all the way, and then connect to these cyclic GMP pathways, cellular pathways, to create the erections. Viagra itself directly is not creating this. Viagra goes and kills the killer of cyclic GMP. When it kills that, the cyclic GMP pool goes bigger. Cyclic GMP is the relaxation of the smooth muscles. And when the smooth muscle is relaxed, blood gushing in, creating the erection. So if you are not having a very good foreplay, etc., after taking that, you are not going to get a very good results. It's very important to tell the patients. Now, so testosterone replacement therapy, improvement in obese subjects also can shrink a little bit here, increase in bone density, muscle strength, improvement of mood and energy level, and then restoration of libido and other sexual functions. So testosterone replacement therapy is acceptable for the late onset hypogonadism, for the late time, like the andropause level, like menopause level, andropause level, not for the earlier ones in the USA. But here and everywhere at the clinical level, if they are having all the symptoms, symptom-related treatment is given to them. And then there are some caveat for that. Have to be in the elderly people, the prostate has to be looked at, and once a year at least to check if they are taking testosterone. So in the remaining time, if I have time, I will just talk about the female sexual dysfunction a little while, very fast. It's a similar desire problems, arousals, and then sexual intercourse and leading to orgasm. This is the sequence of the physiology of the sexual profile. If any of these things are having some problem, and we call it female sexual dysfunction, FSD. And after doing a lot of research for the male and then the current time, there's a lot of work going on for the female because we do not have a proper medications to improve the desire or arousal, etc. Viagra was tried once for the females. When it came first, it wasn't working very well, and we left it as that. But there are more and more is being done in order to get these things. I'm going to give some prevalence studies so that you will understand what's the level of problems that the ladies may have. So this is a very, in our field, it's a very popular slide in a way to say that men thinks only erection, and then it's very easy. Either he performs or he doesn't perform. Whereas they have a lot of it, which is true. I mean, menarche comes in and then they go through the periods and then they have to carry the little child. A lot of things they are going through, and a lot of surgery, a lot of operations, and a lot of deliveries, and finally children's looking after the maternal instinct. They have to be carrying the kids, and at the same time nowadays 50-50 workload, so much of work, coming home late, so much of these things. So what are the multifactorial things? Psychological problems such as depression, anxiety, all these, conflicts within relationships. You can see all these things. Lack of privacy, endometriosis, atrophic vaginitis when it's a menopausal period, all kind of things. And then partner's problem also will contribute to her problems because then she can't do anything.
Just very basic question. Our parents didn't have any problems at all. Families were big. Nowadays, families are zero sometimes. What's the
They didn't have fast food. They didn't have fast food. We put the lifestyle factor. They were not that obese. Nowadays, very easy to become, and hypercholesterolemia, and so many things. Now, in spite of all those buttons, sex tops the happiness index in these major studies in USA. So that's a good thing. So this is a very good study, 1,622 women in the USA. The only thing is in Asia, we never did this study yet. We don't know the prevalence in the females. Lacking sexual interest, that's a desire problem, is about 33%, one lady in 3. Trouble lubricating, that's an arousal issue, similar to the erections, and that's 18%. Unable to reach orgasm is about 1 in 4 ladies in the world, in the Western world. They were suffering. Pain during sex, and sex is not pleasurable. At the end of the day, she's not happy. And the other 2 problems, one is dyspareunia, I mentioned earlier, painful intercourse, due to some physical problems, some kind of infections or ulcer, and etc., or endometriosis conditions, and they have to see whether the pain is in the apex or here in the mid-level, and etc. The gynae will look at all these things. And also it can be psychological factor. So say I'm having headache, that's like that, and there'll be pain also. When the man comes closer, the husband comes closer, she may get the pain. So psychological as well as physical there. But vaginismus, invariably, it's all inbuilt in the brain. The brain sends the signals. The poor lady, she won't know anything about that. She can't understand why this happens. So we have to probe inside what is any sexual abuse in young days or any other issues there. And then slowly give a lot of workshops. This is also like cancer, got different stages, stage 1, stage 2, 3, 4. And the 4 can be very severe, very difficult, a lot of work, a lot of repeated visit, both husband and wife. We have to give a lot of homework, workshops. And finally, most of them can overcome these things. It's a very, very severe conditions. And as I mentioned, the unconsummated marriages happening here partly because of the condition called vaginismus. See, there are two kinds of muscles we have. Skeletal muscle we can control. But here these things is beyond her control. The brain, the moment husband comes closer, she does these things. And it's just complete suffering. As for the hormones, this is male hormone. Male hormone seems to play a better role for the female compared to even the estrogens. Look at this. This is testosterone. Testosterone physiologically play a role in sexual arousal in female, vaginal vasocongestion, sexual dreams, response to fantasies, age at first masturbations, frequency of masturbations, frequency of intercourse, all these things dictated by the hormone testosterone, which we normally call it's a male hormone, but female has about 1/10 of the level is in the female, but it will be amenable. So of course estrogen is also very good for the vaginal atrophy and etc., the cream of estrogen, but nowadays estrogen is having a very bad name because HRT is not very good. So now I'm going up to that menopausal level. At the 49, the beginning of the menopause level, the female problem, sexual problem is about 42%. It progressively increases to higher level, 88% within the 8 years. So that is one of the factors why the ladies may not have, because they have a lot of symptoms. And what happens? The estrogen goes down. And with the estrogen going down, stringing and thinning of the lips, the vaginal lips, reduced sensitivity of the clitoris, which is an equivalent of the penis in the man, vagina narrowing and thinning, and it's become very uncomfortable and painful. If there is a replacement with HRT, estrogens, all things will be better. So the vaginal wall will be even more lubricating and very amenable, very sensitive. But it is now very, the menopausal experts are putting low level of estrogen, a bit of a progesterone, etc., mixing. That is also synthetic as well as alternative, like for instance tofu and etc. is available. And that uncomfortable pain there. Partner sexual interest and drive is also play a role at that time if he's having problem, and his health, his death. So all these things playing a negative role. But the good thing is what you say, there are a lot of positive things also here. I will show that later. These are some of the symptoms. Not everybody is going to get the symptom. 1 or 2 symptoms will be very strong for some people. But here I put urogenital atrophy there. That is a shrinking of the vaginal area. And also some people can get panic attack and bout of rage also. And this is very bad for them, and then overcoming is not easy, but not the good thing is not all of them. As you say, last time nobody complained. No, our mothers or grandmothers never complained either. So this kind of thing also can happen to overcome this. But that's some people like to do that. They want to be like men. But in whatever we say, ladies are at the better advantage in life. You can see the Singapore's expectancy rate. Man is 80 for the death. The women is 85. All over the world, it's about the same. The women are living longer. But if you look the world figure on this, among the people over 100 years, most of them are women. Yeah. So they've got a lot of advantage in living longer. And it is not out of place to continue the sexuality, sexual life, sexual pleasure and intimacy throughout the life. Menopause shouldn't affect them if they have been very positive, sex positive, and been continuing in the 30s and 40s regularly. 50s and 60s definitely is going to be better for them. But if the menopausal symptoms are going to disturb them, and if they start fighting with each other at that time, and things will not work very well. And here it is a 1994 study, but nowadays the figure is even much higher. As you say, they are very active sexually. We don't have the Asian figure here. And so this is my second last slide, I think. Sexual health in the menopausal transition. The effect of menopause and aging on sexual health can vary widely from one woman to another. That figures I say you don't have to worry, you may not get all those things. For some women, the changes are good. For some others, they pose a challenge. If your sex life is good, continue to enjoy it, nurture it, and remain sexually active. This is my last slide. Keep the flame burning. In order to keep the flame burning, it's like a language. Either you use it or lose it. Yeah, that's what I say, 30s, 40s, 50s, 60s, it can continue further. I have had cases of ladies coming with high interest in sexuality when they are 60. In order to match with the husband, Viagra came in and they were all, some of them appearing, some of them matching with them. They go along very well. So the last words here, to keep a lamp burning, we have to keep putting oil in it. In the same way, sexuality too. All these things will create a very good intimacy. Love isn't about when you first meet. It's about the many, many years you spend together when you are trying to keep that flame burning. Yeah? Thank you very much. I will take some questions.